gone through, if anything, we have learned from Lebanon over the years is its resilience. It's been through tougher times, and yet it rose again and became a model to follow within the Middle East. So our thoughts and prayers are out for Lebanon and its people. Right, moving on to bariatrics. Asim, so can you tell us if things were better in Lebanon, would you think that the shift with regard to the supplier would have happened? Do you think it's purely driven by cost, or does the quality play a part as well? Because I think this is a very topical issue in the region as a whole.
Yes, it's a good question, Hazem. I think we've seen the consumer shift in other commodities, not only in healthcare, but that would apply to cars, to mobile phones, etc. It takes time. It takes time before the consumer has confidence in the product, and it's unusual for the consumer to change behavior in a short period of time. So it's not only driven by cost; it also has to do with the quality and also with the habit. Before the crisis, the Chinese staplers were already kind of penetrating the market fairly well, and once some of us tried them and established that the quality was good, the utilization of these staplers became more prominent. The problem is that with the government subsidy, all staplers essentially had the same price because they were cheap anyway, because the government was supporting 85% of them at the Lebanese lira of 1,500. So then, honestly, it didn't make a difference if you get Ezisurg or Fang or Covidian, they're all the same. Now that the government subsidy is removed, I think more surgeons will look at these products seriously and will try to compare the cost, and then will most likely, many of them will choose the Chinese staplers.
Any questions from the floor? I know we're a bit behind on time, so if there are no questions, I'd like to move on to my dear friend and colleague, Dr. Ashraf Haddad. Dr. Ashraf Haddad is the co-founder and co-director for the Gastrointestinal, Bariatric and Metabolic Center in Amman, Jordan. And Ashraf will be talking to us about the trends of bariatric surgery in Jordan in the year 2021. Over to you, Ashraf, if you don't mind sharing the screen.
Okay, thank you, Hazem. Can you see my screen?
Not yet, Ashraf.
Now?
Not yet.
Just give me 1 minute. It's a pleasure to see you all. I hope you can see it now.
Yes, I got you, Ashraf. I got you.
It's always a pleasure to see you all, and I was hoping to see you all in person in Miami, but that's not happening anytime soon. Thank you, Hazem, Dr. Khalid Mirza, and I would like to thank Ezisurg for this opportunity. Bariatric surgery in Jordan is sort of a mix of what countries. This is my case mix disclosure slide. If we look at survey, it described the similarities and discrepancies between different countries. That publication reported about Jordan. Jordan did not add data about bariatric metabolic procedures performed. And this is true. We do not have a registry. Surgeons do not have own registries, most of them. And we have tried in the past to get a registry active, and for some reason there was a lot of resistance. This is our publication about VTE in the Middle East a couple of years ago. And this was important because when we collected data from the Middle East, the trend was sleeve gastrectomy, one anastomosis gastric bypass, and Roux-en-Y was third. And this is the total number of procedures performed in the MENA region by the participating surgeons, greater than 120 procedures. Then in another publication, we saw an exciting trend in the MENA region. And this exciting trend also describes the situation of Jordan. We saw that band-only surgeons became sleeve-only surgeons, and they moved to one anastomosis gastric bypass-only surgeons. Since we do not have a registry in Jordan, I'm going to describe my observations. My observations are similar to these publications. The minority of surgeons doing bariatric surgery are full bariatric surgeons. There's a trend for the majority of the surgeons to be a procedure surgeon. Like, this guy is a sleeve surgeon. This guy was a band surgeon and he never transitioned. The other thing is what Dr. Bassam Safadi described. You know, a lot of the re-sterilization, the medical tourism, we have been trying to enforce guidelines. We try to put guidelines together, but we have no way of enforcing them. This also applies to Jordan. I could tell you that the majority of surgeons re-sterilize equipment and staplers and energy devices, and I'm not sure how efficient a stapler or an energy device that's a single-use device becomes when it's sterilized. I think competition is good. In Jordan, prices or bariatric surgery is not reimbursed by the government or by the private insurance. It's a cash-only procedure. Now, once there is competition, prices would go down, and introducing a new device will force the other established devices to go down on their prices. My hope is that when the prices go down, we could get more surgeons to use the devices properly without re-sterilization and just be doing, using them in a single-use fashion as they're supposed to. Now, another observation is what I call the alternative bariatric procedures, and this has been growing. IFSO now is putting together a position statement describing its recommendation against various alternative procedures. SASI, people are doing the SASI. I do not think it's a founded procedure based on, doesn't have basic science evidence. We are seeing a lot of SASIs because sleeve-only surgeons who face weight regain cannot do any type of a bypass procedure, DS or SADIs. SASI to them is technically easy, and they're popularizing it. And we're seeing patients who are coming after the procedure for a second opinion with various complications. DJB to me represents it's very similar to the SADIs. So it's not really experimental, it's just a more proximal SADIs. We see in Jordan, and I'm not sure if you see that in the surrounding countries, I have seen a rise for the sleeve fundoplication procedures, the N sleeve, the R sleeve. These procedures carry a complication risk of 10% and worldwide, and still people are doing it heavily in Jordan. Ileal interposition, thank God no one does it in Jordan, but I'm sure it's a matter of time before some surgeon claims that they've found a cure for diabetes. Again, it would be wonderful if they're done under IRB, but being a pure private practice business with no regulation, and that applies to the whole MENA region, leads to innovation and experimentation with patients. I think in the region, and you guys can correct me, the only ileal interpositions we see probably come from Turkey. Then there's the sleeve gastrectomy with a jejunal bypass, and people are experimenting with that too, and countless other procedures. I think at the end, we have seen a rise of alternative procedures pushed by what Dr. Muhi al-Banna said, social media. Every surgeon wants to go on social media and claim that they have found a new, better, ideal procedure. Number two, competition is good. I am hoping that the introduction of new competitors in the stapling field is going to drive the price down. The patients will benefit since they are cash payers, and maybe the surgeons would stop re-sterilizing and use things properly the way they are used. We desperately need registries in Jordan and in our regions. And other than Kuwait, I do not think anybody has a registry. So I'm hoping that the next few years, the boom of bariatric surgery in our region would be organized. We will have registries, and we'll be able to put forward meaningful data. Thank you, Hazem.
Thank you very much, Ashraf. Any questions from the audience? I'm aware that I'm taking some time asking questions. Any questions from anyone from our panel? If no one has got a question, Ashraf, I do have a bit of an advantage being from Jordan, and I understand the challenges and the frustrations that you go across. So moving on to the role of the authorities, because unless there is the political push towards regulating a service, I doubt it's going to happen again. Has there been any progress recently with that regard?
Well, Hazem, I've been fortunate enough to be a member of a committee that tried to force and regulate guidelines. Now, the easiest thing as a member of that committee to me was, let's not innovate our own guidelines. As a first step, let's just apply the international guidelines, okay? Just the guidelines that are accepted everywhere in the world that every bariatric surgeon knows. Now, we've written a document and we've submitted that, but there's a lot of surgeons who are politically connected. They don't want that to happen. And the reason for that is some surgeons are convinced that it's okay to do a sleeve on a BMI of a 29 and healthy young female just to make her feel good. And when you leave, and that's everywhere in the world, but when you leave the decision to personal opinions and there's no accountability, you get into these issues. I'm sure in Jordan, Lebanon, even in Egypt, you see these low BMI people getting procedures for no reason. None of these countries lack excellent surgeons. None of these countries lack academic surgeons or academic institutions. However, it's the push through the political backdoors that doesn't allow any of the countries in our regions to even have registries. Let's not even talk about guidelines, just registries. Let's say, what happens to all the SASI patients in our regions? We don't know. So hopefully it's going to get better. We don't want our region to boom in number without control and oversight. And hopefully things would change in all countries.
Thank you. Thank you, Ashraf. Okay, so if no further question, it is time to move on to a colleague from China again, Professor Yang Wang is the Vice President of the 4th Affiliated Hospital of China Medical University, and he again will be giving us another perspective towards the trends of bariatric surgery in China in the year 2021. Professor Wang, the floor is yours if you don't mind sharing your screen.
Okay, thank you for the introduction. It's my pleasure to introduce something from the China mainland. The topic, you know, that rural bypass and sleekectomy is still the okay. Let's start the PPT. Still the major procedure in China mainland. And my presentation is connected to part. The first is the current status of diabetes and bariatric surgery in China. The second, the diabetes in China, and also the second is the status of the surgery in China. The first, we know that now in China mainland, we have the largest cohort of diabetes and also the largest cohort of the obesity. In 2019, I think that worldwide about more than around 460 million of the diabetes, and also 30 years later will be decreased nearly 80%. So how about the data in China? We know that from the adult from 20 to 79 years old in Chinese, around more than 100 million, and in 2019 we estimated that in 2045 the data will be increased to about 150 million. So it's not very large cohort. And also we know that in China, totally territory are only about 109 billion, but the date in the United States around more than two times. So actually most of the physicians just give the patients need to do physical activity, and also most of the patients they just do sparsely and for the to regularly physical activities can participate in leisure activities and the sports. For few patients can do the everyday physical activity, and also for the diet control is also very difficult. For drug therapy, we know there's many kind of drug therapy such as Bagnite and Lidodrine and so on, many different agents. And also more and more Chinese obese, they choose the bariatric surgery because they tried about many measures for many times, but still obese or even become more and more obesity. So that's a Chinese guideline based on the CSFS guideline from the 2013, and also for the Ezisurg. And different is that the Chinese guideline decreased the BMI to 32.5 with or without the metabolic problem, because the guideline changes just because of the Ezisurg decreased the BMI for 2.5 for the East Asia, because for East Asian they're have more obesity to threaten to suffer from this. And also the second stage for the BMI more than 27.5 but less than 32.5 with metabolic problem, we can still do the metabolic surgery. Third, for the 25 to 27.5, most of the surgery in China they will not do this kind of metabolic surgery. And also for the age, the recommended age is 16 to 65, but I present more and more surgery they can finish the old patients more than 65 or even nearly 70 years old. And also that's the guideline for Chinese. Yeah, in the different diabetes or obese, what kind of patient need to do the bariatric surgery, what kind of patient need to do the metabolic surgery, and that's the three different obese stage. Yeah, and the second is what kind of procedure can finish in China mainland. No, that's the date in 2016. We find that the total Chinese surgeon have finished about only less than 7,000 procedure. But at that time, we have the logical of the diabetes and also the obese. We nearly no surgeon would like to do the AGB, that's adjustable gastric banding, and for the rural gastric bypass decrease to the second time for the about less than 2,000 cases. But for sleeve-gastrectomy, we can finish more than 4,000 cases. We still have some OAGB and some others, such as the reversible operations. But cities and the BBDS at that time, we don't have. The rest of procedures around 100. And 1 year later, that's the total date for the East Asia. That's just more around 12,000, not that much. For the Chinese, we have less than 9,000 cases, but we have the larger cohort in East Asia. You know that Japan only finished less than 500, and also for the Korea, less than 500. And the major procedure finished in China and Korea and Japan is sleeve-gastrectomy. We just don't know why the Korea just finished less than 50% of sleeve-gastrectomy. Also, all of East Asian surgeons, they won't choose the bypass surgery as the first choice because of the gastric cancer, especially in Japan and also the South Korea. That's the date finished in 2020. That's satis the CMS database. In 2019, we finished the rural gastric bypass for less than 2,000. And also for the sleeve-gastrectomy increased to around 7,300. So also some sleeve-gastrectomy plus. For me, I can finish around 200 sleeve-gastrectomy plus jejunal bypass per year. And also for GI in China mainland can finish for about 1,500. We don't know. And also just a balloon, because we don't have the license. We don't have the guideline in China, so only about 9 cases. And also the reversible operation can finish around 134 cases. Totally, we know that more than 11,000 in China mainland. We have the last cohort in East Asia. We hope in next 5 years we can increase to about 20,000 or 30,000 because we have the largest cohort. So we know that from the I think that since 2014, sleeve-gastrectomy became the largest procedures can finish in China mainland. So that's the 2020 estimated date finished by 128 hospital, because that's the estimated date, not a totally date. So sleeve-gastrectomy, just as I have mentioned, sleeve-gastrectomy, that's the more than 6,000, and also rural bypass decreased to less than 1,000. We found that the BDS and OAGB is increasing, and also the GGB. That's the date from just 128 hospitals. Yeah, that's the totally date in China mainland since the 2020. We know in 2021, the data will be much more increased, because even the COVID-19 decrease the economy, affect all of our life, but the bariatric and metabolic surgery is increasing obviously in China mainland. So we hope in the next 5 years, China will be the last cohort for bariatric and medical surgery in Asia. Thank you very much. Thank you.
Thank you. Thank you very much, Professor Wong. Professor, is bariatric surgery funded by the government in China, or is it privately funded?
Okay, perfect question. Because I present, I think 10 years ago, China government, they don't believe that obesity is a disease. But in the since we produced I think the CSMBS, so now more and more the government, they believe that obesity and the metabolic problem is a severe disease. So now the national insurance, they can just cover for about 20 to 30%. And also for the patient, they have to pay for other about 60 to 7% of the totally payment. And luckily that in China, we have many companies such as Ezisurg, they can have the Chinese stabler. It's cheaper than Ezisurg and also the codeine. So no, and also the government is just talking about the price with all of the Chinese company. So maybe 1 year later, the totally stabilized price will decrease very cheap. I think less than maybe $800 per operation. Yeah, very cheap. Yeah, but present is still we have still have to pay about $6,000 for all of the stapling fire. Yeah.
Well, as I should have said, I think competition might change the picture of bariatric surgery throughout. I mean, when you got quality at a cheap price, definitely it could be a consideration. Right. Okay. So without further delays, Professor Mohammed Mirza Gari, president of the EFSO MENA chapter, he'll be talking to us about bariatric surgery in the year 2021 in the Kingdom of Saudi Arabia. Professor Mirza, the floor is yours.
Thank you. Well, it was very nice presentation from everybody. It was like we can say in Arabic, hadith du sujun. It is we call it like touchy talk today from everybody, and I find out that we are. Is my screen okay now? With you can see my.
Yes,
screen?
we can see you and hear you really well, Professor.
Okay. So as I just mentioned, we are all together sharing the same problem, the same history, the same step by step. These meetings will solve a lot of issue. As I said from the beginning, we can benefit from each other. Let's say what in our experience here in Saudi Arabia or Middle East. I just want to inform our colleagues in the Far East that the Middle East, actually, we are almost big family. We are big family really. It means by literally, we are big family. Egyptian, Lebanese, Saudi Arabia, Morocco's, Gulf area. We can live in any country of these. We can adapt. We have the same food, traditional culture. So you cannot find any different if you can live in any of these countries. So we have the same pathophysiology of the disease. We have the same problem in patient. We have the we can have the same solution or management in our patients. So even the pathology are the same. So food habit, culture, everything the same. Even socially, we can marry from each other. We have families from Egypt married from Saudi Arabia, from Saudi to. So this culture is a very big open one city. Just names, Egypt, Jordan, Morocco, just names. Otherwise, we are big, same culture. We are different little bit from the Far East in this mean, and we should have the same plan of management. This is slide just to show you as a metabolic communication increased by the glycemic control, depending on the procedure we are doing. As much as the procedure getting complex, effect is more, but the complication is more. So we have to think about it. Bariatric surgery in Saudi Arabia, we started, before we start, it is obesity is a pandemic in our area, especially Gulf region and Saudi Arabia. We are almost 25 to 30% of our population obese, and also almost 32% diabetic. So we are a diabetic country. We are so sweet. Most of our patients having diabetes. So diabetes and obesity are a big issue in our country, and it is a major disease in our country and making a big pressure in our country. So the issue to solve this problem, it is supported by government, by higher authority in the government to solve this issue in the last few years. 100% support to solve this issue. It is one of the 5 priorities health problem in Saudi Arabia to solve it, obesity and diabetes. So bariatric surgery started long time ago in Saudi Arabia in 1990s by open technique, by vertical band gastroplasty, gastric bypass. It was open, and by the time in 1995, Dr. Walid Bukhari and Dr. Hamu, they are very famous in our country. They are very senior surgeons. They started first gastric banding, 6 hours laparoscopy. After that, we started laparoscopic gastric banding, become more popular in 1996. The actual history of bariatric surgery started in 2000, in which we started the gastric band, and then we moved to vertical band gastroplasty. It was popular, and we started doing BBGs, which now abandoned. After that, few years later, we start doing the looking for the quality of bariatric surgery. It is not the quantity. So the idea of bariatric surgery centers and quality was started, and we worked in that parallel to procedure. So we did the gastric bypass, BBG, abandoned gastric bypass, and biliopancreatic diversion. Actually, biliopancreatic diversion, Scopinaro, we have done, me and Dr. Salman. He's one of our senior consultant from Jordan. He's a pioneer and genius surgeon, really. They are lucky in Jordan to have him there. So he was my, I can say my godfather. We worked together, BBD, we did more than 3,000 Scopinaro technique, but now, as you know, we quit that procedure. We are doing, then we moved to mini gastric bypass. So, like Dr. Safadi said, it is not a surgeon procedure or procedure surgeon. We have all the variety of procedure, and we moved in our center to many single anastomosis gastric bypass because of the culture is different, and we found it more suitable. Plus the sleeve. Sleeve started in our country also, like all over the world. It is a, they say, easy procedure for the surgeon and can practice it. So they start to BBG. So we moved in the other line parallel to the all over the world. We have to have our societies. So we started negotiating by obesity society to one surgeon, Dr. Sultan al-Timyas, a eminent surgeon in our country, with Dr. Walid. He's a bariatric family physician or obesity family physician. He's specialized in obesity medicine. So they work together, me and also involved, and Dr. Ahmed. We look together and we seek the advice of Dr. Fobi, in which he advised us to start anything, even obesity club, to be considered a society. We started our obesity club, and then we start our activities. So he joined us in 2008 in our first Congress. It was the first Congress in the Middle East talking about obesity. It was an international Congress on obesity management, 2008. Imagine 2008, the bariatric surgery, obesity surgery was under utilized or under studied in our area in a chapter. So we did the first meeting, then followed by 2011, followed by 2013. The 2013, it was after we established our SASMBS, Saudi Arabian Society of Metabolic and Bariatric Surgery. We established SASMBS, and we did our first meeting in Dubai. It is just to tell our colleagues in Far East, Dubai, it's in Emirates, and Saudi Arabia and Saudi Arabia. So we are the same countries. So our meeting was in Dubai. So we don't have much differentiation between countries. So we did our first meeting in 2013. We invited almost everybody, you know, as a pioneer in surgery during these meetings. So we start looking for EFSO member. We want to be part of the world. We talk in Argentina. We read the issue in 2009. We had 20 members from Saudi Arabia until 2018 to 2020, almost 129 members in EFSO from Saudi Arabia. And our SASM is established in 2011. So this is our steps of doing bariatric surgery. This is our SASM website. These are the members. They are most of them surgeons and different level of experience and seniority. So we started our SASM. We have our website, all educational. The other thing is guidelines. We thought about guidelines since very beginning. In 2004, we start our bariatric surgery guidelines, 2014, sorry. Every 2 years we revise it, 2016, 2019, and now 2020, 21 is coming soon or almost established. My colleague said we are doing something not implemented. But if you see in the department policy in 2005, the idea started with me and they start doing it while I'm working in National Guard Hospital. It was a government hospital. I started the idea, I didn't say nobody will listen to me. In 2005 until 2014, we make the guidelines. Now the second step, we are doing something not going to be implemented, not going to be followed. No, we will not accept this. We start negotiate with the Ministry of Health and we discuss with them and they have already established guidelines, almost copy of our guidelines, and they implement it. So we have a guideline implemented in our government. You see, since when we started until 2019, almost this year is going to be implemented in all hospitals, government and private. They will follow them up by auditing and they should have the guidelines. What I mean by guidelines, if any problem, patient complain against any complication in the court, so the court will go to this guidelines. When they tell the patient or the surgeon, you did the surgery with BMI 33, your guidelines said blah, blah, blah. So this is the guideline, the reference for the judge. So this is a great, great achievement. So we save the patient, we keep the quality. So every 2 years, we repeat the guidelines. I was involved in the guidelines issue since 2005 until now. Still, I'm in charge for guidelines in Saudi Arabia. So these are the members. Every 2 years, we change. We have multidisciplinary team. If you can see these members, you can see family physician, internist, psychologist, gastroenterologist. They all review the guidelines and we update them. This is a bariatric surgery revision or revised committee. We are them. So we review them every 2 years, update them. Then we have our own Saudi Journal of Obesity, which started and published almost now 6 or 7, 8 volumes. It didn't start just like that. We suffered, we fight, and we start looking for this. We look for the resources. This journal was approved and recognized by the Saudi Commission of Health. So they are getting involved. By the way, so this Saudi Health, Saudi Commission of Health specialists, nobody can practice in Saudi Arabia without having the license. Nobody do plastic surgery or neurosurgery if he's not licensed as a neurosurgeon or plastic surgeon. Nobody do bariatric surgery. This we achieve it now. Recently, last 2 years, nobody will practice bariatric surgery unless he has this certificate and license. And the license, we have a criteria, which we make it through the guidelines, how you get this criteria. We have many things. I don't want you to involve in this, but it is very strict. Nobody can just jump and do bariatric surgery. As you know, in some countries, gynecologists do sleep. So the outcome. Anyway, we have a strict guidelines implemented, and we're going on in implementation. We get the issue of Corona, which is problem, challenging, and actions. As you say, during that period, we stopped, like all over the world, we stopped everything. It is a health provider and government work together to protect the public. Well, you see that date, how escalating very quickly from 3rd of March until of March, there was a lot of action taken by government and implemented immediately, no doubt. So 13 or 17, you see how much of action was taken during Corona, and we stopped all elective procedures. You see, this is a holy mosque, how it was so at least 1 or 2 million, it became empty because of Corona. So the action was taken very quickly, and the decision was taken by government, no time for thinking or yes or no. So we took an action. We all healthcare was involved. Bariatric surgery part of this. So the first procedure were postponed or hold plastic and bariatric surgery. After we recover, then we start according to the guidelines that the bariatric surgery should resume as soon as possible, because the obesity is one of the dangerous or risk factor in COVID-19. So every few weeks they come during the Corona. So bariatric surgery during Corona, it is elective. So do we have to do them early or wait? Risk, more preventive protocol and cost. So it was balanced between the benefit and action. So we make our waiting list for obesity patient according to the clinical triage, not based on first come, first go or BMI. So we rearrange our waiting list based on priority, obesity, diabetic patient, super morbid obese with comorbidities. So these patients become priority during that period than the no comorbidity patient. So we have also the many papers. One of these papers are still under, I'm going to publish it, not yet published, incidence of COVID-like symptoms among patients post-surgical during COVID-19 pandemic. So in this study, we want to prove, do we have to stop surgery during COVID? Is it due to risk of patient? We find out that no, it is not, there is no much risk if you take the precaution, the standard, not international precaution. It is just the hospital utilization. We want to preserve beds and ICU for COVID patients. Now, almost in Saudi Arabia, we almost 99% back to normal. Most of the hospitals free from patients, and we are doing all the procedure. I would do this clinical practice guideline. This was published in 2000, few years back, about medical guidelines. It is there. Our situation in 2020 to 20, our number, like everybody during 2019 to 20, dropped down. And now it's going up. So the total number almost 22,000 surgical procedure, mainly sleeve like every other countries, single anastomosis gastric bypass, 20% going up. Now you can see the revisional surgery getting more and more. We have in my clinic personally, 1/3 of my or 20% of my patients, they are post-sleeve for revision, weight regain or symptoms. So revisional surgery getting, and another 10% post-biliopancreatic diversion. I have done 16, 17, 15 years ago. They're coming back to me. So revisional surgery in Saudi Arabia getting more and more, and I expect in the next few years will be at least 40% of the procedure. Others like emergency. So endoscopic procedure, we do the all gastric balloon, ellipse balloon. Regarding the intragastric glycation, it's still in. If you can review our guidelines, we did not add it as a procedure. We didn't recognize it as a procedure, but for trials in the special center, one of the most pioneer in this field, Dr. Aib, he's doing a lot, but it is not recognized in the private or the government except for trial. And my left hand, 2019, this is a Ministry of Health centers. You know that it was started only a few centers. In 2019, 17, and 2020 become 20 center of bariatric surgery under Ministry of Health. What do I mean by center? That means they have their guidelines. The center classified AD, the A, that means all the facilities and the surgeons and the guidelines implemented and the follow-up registration. You see the number getting less in 2020 from 4,600 or 700 down to 2,500 due to the COVID. But these centers, our aim to be more than 20 up to 25 centers in all over the kingdom cities. So each city at least you have one bariatric surgery center, and then Ministry of Health Care will cover 100% free for the patient. But the issue now, insurance cover, they cover only BMI 45 kilogram per square meter. I don't know where is this data they brought it and they implemented. They will not cover your procedure unless you are 45, and they cover only sleeve. This point, everybody thinks that they are superior. The insurance companies, they force us to do what they want, but no, believe me, working in that, and soon, within 1 or 2 months, a new policy which approved by government to bring them down to according to our guidelines, which is 40 BMI and 35 with comorbidities. This is not their option, because if you need patient care, if you are as a surgeon or society strong enough to convince the government, you can do what you want. You can correct everything. Even you can be able to convince and change the insurance companies. Most of the procedure in private, 80% private sector, most of the surgeons now, young Saudi surgeons, they are moving to the private. A lot of work covered by insurance, and they have a lot of work. The obstacles in Ministry of Health, there is some obstacles, but we are going to solve it, and we're working on that. And also we did a lot of work for preventive medicine in obesity. Thank you very much. I'm sorry for being long presentation, but I tried to make it all together to solve most of the problems. Thank you.
Thank you very much, Professor Mirza. That's actually a very helpful presentation. I mean, listening to today's talk, you could see the difference from one country to the other. You've got a very open market model in Jordan and Egypt, for example. You've got Lebanon, who unfortunately currently have got a service which is struggling, and then you're moving on to Saudi. And it seems that Saudi has taken strides towards regulating the specialty. Is this correct?
Yes. Yes, I think also we are working on the registry, actually, but the priority, which comes first? You have to solve the patient quality standard, patient care, then we go for the registry. Now I tell you what, we have signed Ministry of Health with Danbras, a huge contract. If I will tell you how much, you will be shocked. They are charging us a lot of money for this contract for National Registry of Obesity. Other thing, you are, me as a bariatric surgeon, if I want to renew my license for bariatric surgery, they will review my cases. This is what I added. If you renew, you have to review your cases. So we have registry when you renew, and the other thing, this is the next step for registry, national registry.
And Dr. Mirza, is it compulsory to submit data to the national registry in Saudi?
Yes, as you said, if you are a surgeon, what make me force or to make my registry? Two things.
I think we've lost Dr. Mirza. Can you guys hear me? Bassam, can you hear me?
Yes, I can hear you very well. I can hear and see you well.
So we have to have the statistics. So this is
Okay.
new now. In last 2 years, we make a lot of changes, including the registry. So we understand. For example, you mentioned the re-sterilization. Okay, re-sterilization of an instrument. Now you cannot, because when we review your cases, you have to make a sticker of the instrument reference. How many? What type of an instrument? For example, you have 10,000 or 10 cases. I have list of your reference of the instrument. So we try to make it patient. We want to help the patient quality and the standard. We have to fight this re-sterilization. We want to fight the unqualified surgeon to operate by improving. We have now fellowship in bariatric surgery in 2 cities, in Riyadh University, and we are going to establish another one in Eastern Province. So learning, we are supporting the improving the skills of bariatric surgeon by fellowship, and we avoid this re-sterilization issue and reuse of an instrument.
Brilliant. Any questions for Professor Mirza before I conclude with my talk, guys? Okay. Right. I think, I'm sorry, guys. I know we took a bit long. I'll try to be quite quick in my talk, and I'll be talking to you about the trends of bariatric surgery in the United Arab Emirates in the year 2021. Can you guys see my screen?
Yes, clear.
Fantastic. All right. So, DRO, my name is Hazem Al-Momani. I'm a consultant bariatric surgeon based at Abu Dhabi, the United Arab Emirates. It brings me the greatest of pleasure to me amongst such a cohort to share with you our experience of bariatric surgery in the United Arab Emirates in the year 2021. For those of you who are not aware, the United Arab Emirates is quite a unique state within the Arab world. It's located on the eastern coast of the Arabian Peninsula, and it is in fact a federation of 7 emirates rather than just being one country. Now, what that means from a political point of view is that we've got different rules, different regulations, and different authorities in charge of the healthcare across the various emirates. All of these are overseen by the Ministry of Health. For example, we in the Emirate of Abu Dhabi, which is the capital of the United Arab Emirates, are governed by regulations by the Department of Health. In Dubai, the Dubai Health Authority is in charge of the healthcare sector, and in the remaining 5 emirates, they're overlooked by the Ministry of Health. The total population of the United Arab Emirates is just around 10 million individuals. The great majority of these are expatriates. Now, this makes a huge impact with regard to the provision of bariatric surgery, because while bariatric surgery is provided by some insurance to the Emirati people, expats insurance schemes do not tend to cover this surgery. The distribution of the population as well within the United Arab Emirates is quite unique. The great majority of people live within Dubai, the famous city. Then we've got around 20% living within the Emirate of Abu Dhabi and another 20% living within Sharjah. The remaining 4 emirates only constitute less than 10% of the total population of the United Arab Emirates. Similar to other countries within the region, obesity is quite prevalent within the United Arab Emirates. Around 3/4 of the adult women and men population are either obese and overweight, and this is based on officially published figures. And childhood obesity is the another big challenge for the future generation, where nearly 1/3 of the children are either obese or overweight. As for the bariatric surgery within the United Arab Emirates, I'm really proud to say that I live in a country where such a service is very well regulated and very well organized. It is a recognized specialty, a recognized treatment for the disease of obesity. And bariatric units within the Emirates of Abu Dhabi will need to report their data to the Department of Health on a quarterly basis. And we have predefined key performance indicators that we would need to meet. Failing to meet these indicators can have consequences. The criteria for eligibility for bariatric surgery within the United Arab Emirates as well is very well defined, and it's based on internationally recognized qualifications, qualifying criteria. For example, if your BMI is less than 35 and you've got a poorly controlled type 2 diabetes, you are qualified for bariatric surgery. And as I mentioned earlier, this service is covered by insurance for Emiratis, but for the expatriates, it is not. So when we look at the market of bariatric surgery, we need to divide the United Arab Emirates. The majority of the hospitals providing these services are based within the two big Emirates, which is Dubai and the Abu Dhabi. In Abu Dhabi, the majority of the procedures provided are covered by insurance. There's a well-defined list of acceptable surgical procedures and based on predefined eligibility criteria defined by the Department of Health. Failing to comply to these regulations will have major punitive consequences. And this is what we were talking about earlier, about the political willpower and the push towards implementing these regulations. Any deviation can have major consequences. And not long ago, nearly 3 years ago, a unit was fined for breaking these regulations, and they had to pay a fine around $5 million US, and the surgeon had lost his license. Similar to other countries within the region and perhaps the world, the commonest surgical performed bariatric procedure in the United Arab Emirates in Abu Dhabi is a laparoscopic sleeve gastrectomy. This is followed by the one anastomosis gastric bypass, and in third place, we've got the Roux-en-Y gastric bypass. Now, this data is not supported by any national registry. We don't yet have a registry within the United Arab Emirates. However, we in the Emirate of Abu Dhabi have got a club for the bariatric surgeon where we could talk to each other and share our experience. And this data I'm presenting here is based on the data shared from colleagues. Then we move on to Dubai. Dubai's market has got more of the open market business model. The majority of the surgeries are privately funded because the great population, or the greatest majority of population living in Dubai are expatriates who do not have insurance schemes that cover the surgery. Again, laparoscopic sleeve gastrectomy is the commonest procedure, followed by the one anastomosis gastric bypass. And the main difference between the market in Abu Dhabi and Dubai is that certain procedures like the endoscopic sleeve gastroplasty, or for example, the recently publicized vertical gastric clip, they are illegal to be performed within the Emirate of Abu Dhabi. However, in Dubai, they can be performed because of a looser business model in Dubai in comparison to Abu Dhabi. With regard to the future of bariatric surgery and the new treatments being promoted, SASI and SADI are being performed by a couple of units. However, they are done under research settings, and they need to get pre-approved before they're being performed. And the new chapter, similar to other services within, with other units within the world, robotic surgery is being introduced. We've got a couple of units who are starting their work in delivering robotic bariatric surgery. So the future is bright when it comes to this specialty. As with regard to the limitation of bariatric surgery within the United Arab Emirates, as I said, the great majority of the population are expatriate. The United Arab Emirates is a rich country and the cost of living is quite expensive. And as well, healthcare service to pay for out of pocket is quite expensive. And this is where medical tourism happens within this part of the world. A lot of our patients would travel to countries like Jordan or Egypt to have their surgery, and then they come back to us. This is proving to be a bit of a challenge to us, as surgeons operating within the United Arab Emirates, because as Professor Al-Banna mentioned, a lot of these surgeons, they're not exactly sure what sort of surgeries they've had. There is no documentation of what they did. The other thing is the cultural norms and traditions. Bariatric surgery is still a bit of a, I won't say a taboo, but not widely accepted as a treatment for obesity amongst the public, even though the government is supporting it and there are talks about obesity and its treatments. The last bigger challenge is what modern civilization is facing, which is the reducing cost of poor quality yet abundant food, which is going to make the obesity and diabetes pandemic even worse. The main challenge we're going to face in the United Arab Emirates in the future is the reduction in insurance reimbursement with the payments we're going to be receiving for providing the service. So, for example, we are anticipating that the cost to be reimbursed from the insurance for performing, for example, a gastric sleeve will be dropped by about a third. The other challenge that we've got is from the insurance point of view, they don't discriminate between a primary procedure or a revisional